Welcome to part 1 of cardiovascular disorders in children. This video lecture will provide an overview. By now, you should have a good working knowledge of what the normal heart rate and blood pressure is in an infant and child. In addition, you should have a good working knowledge of circulation and cardiac function, as well as cardiac anatomy. If you don't, then you need to review it so that you understand the various congenital heart defects that will be discussed later. There are 3 YouTube videos that you need to watch. There's one on fetal circulation. You need to know that now. You will need to know that for 174, but it's not going to be presented there. Another one discusses the circulatory changes that occur at the time of birth, and the third discusses a patent foramen ovale and a patent ductus arteriosus. Congenital heart defects are fairly common, and some are repaired and others are left alone. We have a variety of defects. We have the cyanotic and the acyanotic. So some of them, the kids are blue, and the others, the kids are pink. So kind of put them in that kind of a category. So with the cyanotic defects, we have left to right shunts. The oxygen saturations are below 90%, and some of them can go, although this slide says as low as 70s. When these kids get into real trouble, they can be in the 50s and 60s. But what you'll see in some of them, their norm is in the 70s. That's when they're functioning as well as they're going to function until we can actually do a surgical procedure. Oxygen saturation that dips below that 85% mark will cause cyanosis. So you want to be looking at that when you're assessing your child. And where do you look? Look at their lips, and on the babies, look at their buccal mucosa. You'll see it in their tongue. You won't miss it. Over time, these children will develop clubbing. Now, you usually think of clubbing with your COPD patients from smoking. Well, these children have it as a result of chronic hypoxia, and so these capillary beds are increasing, and they end up with little clubs at the end of their fingertips by around the age of 4, 5, or 6, depending on what cyanotic defect they have. In addition, they develop polycythemia. So look that up and see if you can figure out why they have this blood disorder. When we look at the cardiovascular disorders in children, 1% of all live births results in a congenital heart disease patient. And sometimes they have more than just the congenital heart defect as their problem. There's a variety of syndromes also. There can be an infectious heart disease, which is considered an acquired disorder. And there's Kawasaki's disease. There's a YouTube video on that. Endocarditis, and rheumatic fever. We don't see rheumatic fever as often anymore because we treat strep throat, and that's the cause. And then we have congestive heart failure, and this is usually a result of some type of a congenital heart defect and heart disease. Risk factors for developing these defects, well, we can have syndromes. So I already mentioned that. So trisomy 21 is Down syndrome, which we learned about last week. And frequently these children have some type of a congenital heart defect. Trisomy 18 and 13s, many times these children don't survive, but we are getting better and better with our treatment modalities. And so we may see some of these, especially in our NICUs. We have DeGeorge syndrome, which I see fairly commonly. Vater syndrome, and then Turner syndrome, which is an XO on the sex chromosome. So you have a female, but she only has one X chromosome instead of 2. Fetal alcohol syndrome can also cause congenital heart defects. Congenital rubella syndrome can cause it. And then when I have here maternal diabetes, what we're talking about is women who enter a pregnancy who have poorly controlled diabetes. So their sugars are all over the place, and they have a high risk of developing a baby with a congenital heart defect. So the important assessments, this is what the parents will complain about, is the feeding patterns. The baby is taking longer and longer to eat, and they're not very satisfied because they get so tired, yet they're still hungry. They have activity intolerance. They're slower and less energetic. Remember, some of these disorders don't need to be repaired immediately, and so when the child gets bigger, now they're more and more symptomatic, and that's where we're going to see this loss of activity tolerance. They may have fluid and electrolyte imbalances, and those typically are going to result in some type of an arrhythmia. And then we have our developmental milestones. Because they can't keep up with their peers, they end up being delayed. Because of the poor feeding patterns, we're going to see a failure to thrive. On the physical assessment, we start to hear murmurs. We may hear a bradyarrhythmia or a tachyarrhythmia. We might hear an abnormal rhythm. We may have rubs and clicks. One of the things that you want to watch when a child is admitted with a congenital heart defect is the precordium. And basically, that's where the heart is right next to the sternum, and you're watching for the pulse. And when we call it quiet, when you look at that, you don't really see that heartbeat. But when it's bounding, this heart is enlarged and it's working overtime, and so you can literally see that heart beating up against the chest, and that's called a noisy precordium, even though we don't have to listen to it. We want to assess the blood pressure in all four extremities, and we compare uppers and lowers, and we compare side to side. And this is especially important when we have a coarctation of the aorta. That's how we find it. Pulmonary-wise, we're listening for adventitious sounds. We're looking at their work of breathing. Are they short of breath? Are they sweating excessively? There may be hepatosplenomegaly when a child is going into CHF, and then we look at their peripheral perfusion. Are they cyanotic? Do they have delayed cap refill? Do they have edema? And remember, the smaller the kid, we're going to be looking at generalized edema, including on the face and around the eyes. You want to palpate the peripheral pulses and compare them. And then I have cap refill down here a second time. So do remember, when a child has chronic hypoxia, or it's also hypoxemia, so it's low blood oxygen level, it results in cyanosis. As a result, they have polycythemia, they develop the clubbing, and at the same time, we see failure to thrive. There can be chest wall deformities, like the pectus excavatum, and that's only because it's compressing against the heart and it's interfering with its ability to function. Keep that in mind. It's not something that you really need to remember. Here's the list of our nursing diagnoses that are appropriate for our cardiac kids. So definitely a decreased cardiac output, ineffective breathing pattern, imbalanced nutrition, ineffective tissue perfusion. These all should be common sense to you when you think about what a cardiac defect is. And you can go on down the line. And as you progress through the cardiac defects, you'll see where all of these fit in. Our planning and interventions, it really depends on, is this a neonatal problem, being the first 28 days, or is it a pediatric problem? Are we treating this child as an inpatient versus an outpatient? Are they pre-op or post-op? Because sometimes we're holding off on doing any kind of repair until the kid gets big enough, and this child will come in and have more than one procedure. Diagnostic evaluation will include an echocardiogram, and they will also watch the flow on that echo. They do cardiac catheterizations, and sometimes during the cardiac catheterization, they can also fix a defect partially to improve flow. We do chest x-ray so that they can look at the size of the heart as well as the lungs to look for congestive heart failure. Some of the defects will be looking at EKGs, but that isn't a real big thing with the congenital heart defects. And then on the CBC, and I have some questions here. What will it show when a cyanotic defect is present and why? And what are the risks associated with these CBC results? And you need to really critically think through this because it can end up being a complication later if we don't pay attention. Complications of congenital or acquired heart defects can result in congestive heart failure. So we have a volume or a pressure overload, or we can end up having a dysrhythmia, so a dysfunction of the rhythm of the heart that can result in a CHF, and believe it or not, some kids can have an MI. So now we're going to move on to part 2, which is going to address congestive heart failure in children.